Well, all right. Thank you for being here. We probably will have a decent amount of time for questions. I actually am prepared with a bunch of slides, though, and so I go through them relatively, hopefully efficiently, because if I didn't, then we'd probably be here for 2 hours for the first part of the slides and 2 hours by the time we actually got to talking about sports-related concussions with the risk of dementia as the topic of the whole talk. So you guys know, I think that I'm Jeff Cory, so Dr. Jeff Cory. I'm the clinical neuropsychologist at the Neuroscience Center here, one of the two. And neuropsychology is hopefully an expert field with regard to traumatic brain injury, including concussions, and a lot of the research that's come out of or has been done in regard to concussions, repeated concussions, and the possibility of a dementia has been done within or in concert with neuropsychology. So pretty easy to tap into the literature from the science and see what that says about all this, and then use that to inform our clinical work. This guy turned off here, so I'm trying to get it back on. Not that that really matters that much. Okay. So what was this? A year and a half ago now, Will Smith was in this movie, and he was portraying Bennett Omalu, who's one of the principal brain pathologists that sliced up some brains recently, and in particular Mike Webster's brain. He was the Pittsburgh Steelers lineman who committed suicide, and then Omalu identified what he called chronic traumatic encephalopathy. He wasn't the first person to use that term, but he said, hey, wait a minute, this is a football player who's had a lot of head trauma through his career, and what I'm seeing is not a normal brain. And so I think this is a brain with damage related to having played football and multiple concussions. So that's where a lot of this came from. And now there's a group that is sort of a splinter group run by Anne McKee and Robert Stern, who's a neuropsychologist, and Chris Nowinski, who's a Harvard football player, graduate, former wrestler, concussed guy who helps to get the brains donated to the folks in Boston to take a look at those. So got a lot of press about concussion. We've got NFL players who are suing about dementias. Neuropsychology actually is front and center with regard to doing the evaluations of the retired NFL players who may have some cognitive impairment and may have a claim about chronic traumatic encephalopathy that they sued about. So we certainly have, these are the results from the Boston folks saying that they studied 91 brains, and 87 of those brains seem to have CTE. So we certainly know that we see a lot of media, a lot of press about the topic. The Supreme Court has had some wranglings in front of it about whether the settlement to the NFL players that's been proposed should be accepted. So a lot of litigation and press and so forth about brain damage related to playing sports like in the NFL. However, with a lot of the publicity we in the media, we actually, in my opinion, and at least in neuropsychology, there's a lot of hype, and the hype has actually outstripped the science. And so this is from an article written by Gary Solomon, who's a neuropsychologist, who's I think he's like the neuropsychologist for the Nashville Predators or one of those teams back there. He's the consultant, and then Alan Sills is a sports medicine doc. And this quote that they have is that there are some commonly held beliefs, and it may be unpopular or even sort of dangerous to challenge those commonly held beliefs. So if you work in sports medicine and you share the actual concussion evidence base and even criticize the evidence that has been put out there in talking with patients, oftentimes there's skepticism and disbelief. What do you mean my multiple concussions haven't been proven to cause the memory loss or depression or suicidality or concerns about dementia that I feel like I have. Are you telling me there's not good enough science there? That's something I'll be skeptical about, because it sure feels like, based on what we see in the media, that there's a heck of a lot of good evidence in that way. I feel like I'm in an interesting position as a neuropsychologist. Awkward might be a better word in some ways, because I know a lot about brain injury and concussions, and I pay attention to the science, and I treat them, I evaluate them, but at the same time, I actually have to push back against some of the hype and the concerns that exist about the effects of concussions and what concussions really are and what post-concussive syndrome is and how much there might be a risk of dementia called CTE from having concussions. And so I believe personally that even ethically that it's actually best to call it like it is and to give people the best evidence rather than just kind of buy into the hype. And so that's the way I'm approaching this. But certainly there's so much that is kind of out there in the world and the media at this point that some of what you'll hear tonight is going to obviously fly in the face of some of the that media hype. But it's based on science and the studies that have been done, or when there's actually insufficient evidence scientifically, then that can be pointed out too. So the talk has a few parts to it. First, talking about what is a concussion and how's the brain injured. I'll go through that pretty quickly because many visiting here among the four of you know a lot about that or know enough that I don't have to go through it at great granular detail, but we have some slides to go through that way. Talking about sports concussions, some facts and figures. Those are basically just taken out of the epidemiology literature in terms of how frequently athletes get concussed and in which sports and that kind of thing. What does recovery from concussion look like? What is post-concussive syndrome? And then getting to the heart of the matter in some ways, why all the concern about sports concussion? So we know about this idea of second impact syndrome, and without getting into it in the midst of just giving an outline to the talk, second impact syndrome would essentially be if you get concussed in a sporting event and then you're taken out, but you're put back in the same sporting event if you have another concussion in that sporting event, possibly because your brain was vulnerable to another concussion because it just got concussed, then you could potentially die if your brain swelled and then you actually didn't survive that. Then CTE, which essentially used to be known as boxer's dementia, dementia pugilistica, or punch drunk syndrome, but now it kind of has a more modern term associated with it, chronic traumatic encephalopathy, and that's the specter, obviously, of dementia arising from repeat concussions. I'm actually going to talk about when treatment for concussion can actually make someone worse rather than better, which is one of those things that runs a little risk of running contrary to kind of the conventional wisdom and the typical treatment of concussion and management of concussion. And then talk about balancing the risks. If there, what are those risks about sports participation? Should we let our kids play football and soccer and contact sports that have risk of concussion versus the benefits of participating in sports? And then some Q&A. So here's a definition of concussion. This comes out of the consensus statement from the International Conference on Concussion in Sport, which happens, if not every year, every so often, every couple of years, and has gone from like Vienna to Zurich. I don't know why it's always in Europe, but there you go. And so their consensus statement about what concussion is defined in this way. It is a brain injury, and it's defined as a complex pathophysiological process. So it's brain damage that involves chemicals and circuitry and so forth in the brain, and it's fairly complex. Go figure, because the brain's a complex organ. And it's induced by biomechanical forces. So it doesn't just come on when you're lying in your bed, obviously. There has to be some type of head trauma, movement of the body, some type of G-force in effect affecting the brain biomechanically that causes that disruption in brain functioning. The injury typically results in rapid onset so very quick, not a lot of delay in onset of symptoms. It's short-lived impairment of neurological function. I have a graph to show you just how short-lived it typically is. And then it resolves spontaneously. It's not to say that there isn't a possibility of kind of a frontier of medicine in terms of could we administer something or give someone a medication or something like that soon after that would help the brain to get back on balance and return to its health a little bit quicker. But essentially the brain and the immune system know how to get you back on track spontaneously, which is exactly what happens. In some cases, signs and symptoms may evolve over minutes to hours. If you have someone who's not very symptomatic or minimally symptomatic right away, and then there's the significant change in their symptoms later, particularly if they look like they're deteriorating and becoming more out of it, or have a seizure or something like that, then certainly they need to go to the ER to get evaluated at that point, because they could potentially, essentially the risk is for a bleed inside the skull that needs to be treated potentially through neurosurgery. However, that's rare, and pretty much if you have a symptom that comes on 2 days, 3 days, 4 days later, a week later, 2 weeks later, then chances are much greater that it's not related to the concussion and could be related to something else, because what we call concussions in a way is worst first phenomena. So those symptoms are worse right at the beginning and immediate onset, if not perhaps within hours. And then the acute clinical symptoms of a concussion, they're basically a functional disturbance rather than a structural injury. And that's really important to know, because we tend to think of brain injury as being damage to brain cells, and that is the case with moderate to severe TBI. But concussions are mild traumatic brain injury, and mild traumatic brain injury or concussions is basically a disruption of the brain's metabolism and chemicals rather than the actual any actual damage to the structure of the brain cells. So there's no abnormalities typically seen on neuroimaging studies. If you do a CAT scan of the head or if you do an MRI, typically not going to see anything, which unfortunately on the downside of that, sometimes the ER folks might say, well, you didn't have a concussion because your brain scan's normal, but that's not actually a reliable way of saying you couldn't have had a concussion. Most concussions aren't going to show up on brain scans, so you need to look at other information about whether someone had a concussion. That being said, though, not every head injury is a concussion, and that's something I deal with in my practice all the time, is helping to sort out what probably was a concussion that involved an injury to the head versus what probably was not. So what is the pathophysiology? What happens in the brain and chemicals and so forth in a concussion? The term that's been proposed, and you see in the literature, is from Chris Giza and David Hovda, who are at UCLA, and it's Neurometabolic Cascade. The cascade essentially means that there's sort of linear time sequence of the different changes in chemicals in the brain because of the biomechanical forces. And the neurometabolic, again, references that it's not structure of brain cells, it's actually more the metabolism and the chemicals, specifically things like potassium and calcium and glutamate, some of these chemicals that help the brain to do what it needs to typically do. And so essentially it's time-limited dysfunction of metabolism in the brain. It's an energy crisis in a way. There's reduced cerebral blood flow. That's what this is showing. If this is normal here on the dotted line, then this is reduced cerebral blood flow that's happening. Notice the timeline. This is minutes, 0 to 30. This is hours, up to 24. And then here's days. This does not extend into months and years, this kind of dysfunction here. But you have essentially spiking of abnormal levels of some of these chemicals with a reduction in the blood flow going to the brain. And so the brain is kind of in an energy crisis just at the time when it actually needs a lot of energy to be able to help itself to kind of get back on balance. But there is, nevertheless, a gradual reversal and return to normal brain metabolism within several days of the concussion. Typically 7 to 14 days is what you'll see in athletes in terms of reversal and a return to normal brain functioning. So some facts and figures about concussions. With sports-related concussion, we can talk about estimation of how much this occurs annually. Sports concussions are estimated to occur about 300,000 per year in the US. In terms of all sports injuries, this is sort of interesting because we hear so much about it, we think that it's probably even more common as a portion of the type of injuries that people end up suffering in sports. But it's about 6% of injuries in college athletes, so 94% are actually non-concussion. 9% of injuries in high school athletes, so now you're getting into maybe 1 in 10 people. You know, you're going to certainly see some concussed high school athletes. And then football players, you know, they're up to 55% of all concussions, but they also have the most participants. So in some ways, it's not really it's kind of more like a per capita type of prevalence of concussions. And the sports that are most at risk or have the most number of concussions include wrestling, football, soccer, basketball, ice hockey, lacrosse, and cheerleading. We don't oftentimes think about. One of the things that's notable, I don't have a slide about this, but all of those sports except for cheerleading, there's a greater number of concussions that happen in games than instead of in practice, versus in practice, right? Much less concussions in practice. Sort of makes sense because you're going all out in games. Cheerleading's not the same thing because you're doing the same stunts and having the same falls whether you're practicing or actually doing it in front of anybody. So what do we know more about sports-related concussion? We know that loss of consciousness is actually relatively infrequent with sports concussion. Another thing you might hear in sort of the ER talk about concussion sometimes is, oh, well, they didn't have a concussion because they didn't lose consciousness. Most people who have suffered concussions have not lost consciousness. However, every single person who's suffered a concussion has an immediate alteration of their consciousness. If you don't actually get out of it and cognitively, I got my bell rung, and I'm having trouble thinking, you didn't have a concussion. The definition of a concussion is, obviously, if you got knocked out, you had a concussion. But you have to have had immediate alteration of consciousness. And I do see a lot of people who said, well, I had a concussion, but when we go back and we talk about the actual injury and what they recall, granted, this is, you know, retrospective, it's not perfect, but they sometimes say, no, I felt fine until, you know, a while after. Then you didn't have a concussion.
That's definitely a concussion.
Correct. Yeah, that's right. So 10% of athletes have a sports concussion with witnessed loss of consciousness, but we were talking about the other majority does not. So amnesia, lack of memory, difficulty making memories, you know, repeating questions and statements and so forth after the injury, less than 50% of sports-related concussion. So that just means that you can't say, well, if you're not having trouble making new memories and repeating yourself, then you didn't have a concussion. And then memory for loss of events prior to the injury. So after the injury would be called post-traumatic amnesia, otherwise known as anterograde amnesia. That's difficulty making memories for after you got your head hit. From loss of memory from before is called retrograde amnesia. And that kind of loss of memory from before the impact is even more rare. In fact, in my opinion, it actually makes it somewhat of a more severe concussion if it's there, that loss of memory from before. And then overwhelmingly, most symptoms and effects of concussion in sports, as well as not in sports, but we're talking about sports concussion here, have immediate onset. So again, seconds, minutes, less commonly hours post-injury. So what does concussion recovery look like? The answer is it looks really good. This is the same slide from before. Things get basically back to normal by somewhere here. This is probably 9 or 10 days. Doesn't mean the person wouldn't be feeling off their game, but essentially the chemicals and the blood flow and the brain metabolism, that neurometabolic cascade we talked about, normalizes by about 10 days later. And a lot of the normalization actually happens even before that. So acute symptoms in recovery from concussion, again, most severe symptoms, it's worst first. They're evident within minutes of the injury. If you have someone who's getting worse in their symptom complaints after suffering any type of traumatic brain injury, I am getting worse over time. I am having more memory problems, more symptoms over time, they're worsening over time. That is absolutely, positively not what happens in any traumatic brain injury, including concussion, and that means something else is going on or their report is not reliable. It's worst first, and then it gets better. So delayed symptom onset is pretty much rare to non-existent. Classic symptoms of concussion, like nausea and vomiting, they're actually really rare. People don't tend to puke. Measurable symptom improvement within hours of the injury. So again, a lot of the change happens immediately, but so does the improvement. And then about 7 to 14 days is the timeline for about 80 to 90% of folks' gradual symptom recovery, brain's getting back on track. We're going to get to the persistent post-concussive type syndrome in a minute, but here's a reference to a meta-analysis. So, when you collect a bunch of research studies together and aggregate all the data, you get sort of better interpretation. You get stronger results than you had with a few studies all by themselves. And so these are neuropsychologists in Florida who have done a lot of research on traumatic brain injury and concussion, post-concussive syndrome, and have done a couple of meta-analyses. And so here's what they found with aggregating the studies about sports-related concussion in terms of the impact on neuropsychological functioning. So that isn't typically headaches per se or other physical symptoms. That's going to be mainly the irritability, the short-term memory difficulties, so cognitive stuff and emotional mainly. So 21 studies, 790 athletes, a bunch of control people because they want to see what's different or what might change if people have not had concussion and they had an injury to, say, their knee or something. There's reasons that's important to have those controls there that I won't necessarily go into, but within about 24 hours of the injury, there's moderate effects. So if you tested someone's cognition within about 24 hours of the injury, then you're going to see, okay, there's something here, definitely. This person's off their game. There's some impairment. But by day 7, you actually don't see, on the whole, aggregating the studies, you don't see neuropsychological dysfunction in pretty much anybody. There are about 10% of people with sports-related concussion who have a persistence of symptoms, but we'll see what that looks like in a minute. So what's post-concussive syndrome? This is where there is a way to talk about this that the literature supports, but it's different than what you usually hear. Because what you usually hear is post-concussive syndrome is any symptoms that are subsequent to a concussion. Sometimes they're even diagnosing a post-concussive syndrome, just meaning the symptoms that they walked into the ER with 10 minutes after they had a concussion or a day after or something like that. Post-concussive syndrome actually means that the symptoms are persisting beyond that typical window of spontaneous, successful, full recovery from symptoms that happen in concussions. So it's really, you could say, persistent post-concussive syndrome. What is that? So we say PCS for the initials. So it's a set of symptoms initially caused by a mild injury to the brain, that neurometabolic cascade we talked about. They're most often self-limiting and spontaneously resolving. So that's where we started into this slide. But then they persist beyond the typical concussion recovery time of a few weeks. The best meta-analysis that's ever been done of recovery after all types of concussion, mild traumatic brain injury, suggests that really there's nothing that you can find, again, on the whole in a population of concussed individuals by at the very longest about 3 months after the injury. So that actually means that we need to be really cautious treating people for presumptive brain injury even somewhat sooner than 3 months, but certainly after 3 months after the injury, because then you're potentially treating something else. And the symptoms that we might call post-concussive symptoms, well, they were initially caused by the brain injury, the mild TBI, but they are actually maintained by a bunch of other things that aren't actually brain injury. And then post-concussive syndrome, I mentioned this at the beginning of the slide, I think. It's not just any kind of symptoms that someone has after a concussion. And we'll see why you need to actually determine what those symptoms that someone's reporting, say, 4 months, 5 months, 6 months, 2 years later after a concussion, assuming the concussion happened, you need to determine what those are actually due to. Because if we treat something that is not the cause of the symptoms, we're spinning our wheels and we're failing to treat what the actual cause is. So we'll get into that in a sec. So post-concussive syndrome in athletes, more than 90% of athletes report full symptom resolution within 7 days. Now, granted, they're like healthy folks. They're motivated to get better. Their bodies can recover from injury because they're healthy. That may be different than people in the everyday community, but this is what we know about athletes. I mentioned earlier about 10% of athletes are the ones that we would say, okay, you're in a prolonged recovery pattern. And interestingly enough, prolonged actually just means more than 7 days. So next slide, I'll tell you a little bit more about the time frame there. So this is an article, good empirical research, prospective research. It followed people forward from the time they were concussed. And Mike McRae, who's at Medical College of Wisconsin, who's a neuropsychologist and is one of the principal investigators on it's a study being done by a group called the CARE Consortium, which is going to be the biggest NCAA athlete concussion and Department of Defense military soldier concussion study that's really going to tell us even better, more than we know now. So Mike's a PI on that. So this is a study that determined about 10% of concussed athletes have a symptom recovery longer than 7 days. And interestingly enough, these folks here, there were persistent symptoms reported by the athletes in that 10% group 45 to 90 days after the injury. But there weren't any deficits that were found on objective neuropsychological, so cognitive testing. And actually, sometimes we test postural stability. You guys know about this. And so we're seeing whether someone's balance is off, essentially, as a function of a concussion. And there were no significant deficits that persisted in these athletes on balance testing. And so it suggested, actually, that functional impairment, even though these are folks who are complaining verbally of still feeling like they're not recovered from their concussion, the cognitive testing and the balance testing wasn't showing functional impairment. So there may be something about the verbalized complaints, the person's complaining about feeling like they're not recovered, but in terms of functional objective testing, it's looking like they basically are. So here's the thing about post-concussive symptoms. They're not specific to concussion. Can dizziness happen because of concussion? Sure. Can it happen because of something else? Yes. Can irritability happen because of concussion, but also because of something else? Memory difficulties, sleep disturbance, all sorts of things that are actually in the realm of post-concussive symptoms can be caused by things other than a concussion. There's plenty of things in medicine, right, that are not specific as symptoms only to a particular cause or diagnosis. They're caused by other things, and that's part of what medicine is about, is trying to figure out what's causing symptoms that aren't necessarily specific to any one thing. So here's what's happened. Grant Iverson is a neuropsychologist who's at Harvard, who used to be in British Columbia. He developed a questionnaire called the British Columbia Post-Concussion Symptom Inventory. And all he did was he just went to the ICD, which is the Diagnostic Manual in Medicine, and he said, what are the criterion symptoms for post-concussive syndrome, because they exist. Things like dizziness and irritability and memory problems and sleep disturbance and so forth, light and sound sensitivity, things like that. And so he and his colleagues said, all right, well, let's create a checklist. And the checklist essentially is, in the past couple of weeks, how frequently and how severely have you been having these things? Doesn't say why, it just says how frequently and how severely. With post-concussive syndrome, in theory, if those are criterion symptoms and you endorse a lot of them, then you'd be probably said to have post-concussive syndrome, right? Because you're endorsing a lot of the symptoms of this syndrome, of this conglomeration of these symptoms. However, what they did at this, after they created the symptom inventory, was they said, let's just see. We know these are, some research had already been done in neuropsychology saying these symptoms aren't just in concussion. But they said, how about this? We'll take some people from groups who have been identified for this study who have never had a concussion, but they have some other condition. And let's see how much they light up the Christmas tree of this particular set of symptoms that we would consider to be post-concussive. It would be a totally different story if I told you that this person had, or these groups of people had concussions, but keep in mind, they did not. So post-concussive syndrome would be diagnosed in 9 out of 10 people with depression, but no concussion. 9 out of 10 people with fibromyalgia as a chronic pain condition, but no concussion. Chronic pain in general they've done without a fibromyalgia diagnosis. Even healthy college students who have been told to imagine they had suffered a concussion, and then what symptoms do you think that you have? And then healthy community volunteers. Do people sometimes in the past couple of weeks have some headaches and some irritability and some sleep disturbance and some concentration problems? At some baseline, yes. That doesn't mean the healthy community volunteers would always be diagnosed with a post-concussive syndrome, but the symptoms aren't, frankly, absent.
Can I interrupt you with a quick question right here? Like the depression and fibromyalgia, what about the other way around? Can a concussion cause then the depression down the road, and the polymyalgia rheumatica is a condition? Can that be related and caused?
So yes and no, because yes, someone could have depression that results from life changes from a concussion. Concussions themselves don't cause depression symptoms because of ongoing brain injury, but as a person's emotional reaction to having suffered a concussion and the changes in their life, yes, they could have depression. But rheumatic conditions, no. Concussions don't cause that. So how do we know if post-concussive symptoms are actually due to concussion? Here's the worst case scenario in some ways, I think, in medicine. A doctor asks someone what they're experiencing symptom-wise. They tell them a bunch of these things. And either the patient is suggesting to the doctor or the doctor is asking, or somehow it comes up that before you had these symptoms, did you have a head injury? Or a documented, known diagnosed concussion. What ends up happening is the doctor might say after, therefore, because of. If these symptoms are after the head injury or concussion, therefore they must be because of the concussion. Well, that's not called differential diagnosis. That's just called pinning the tail on the donkey of one thing that it might be due to, because you presume it looks like a post-concussive syndrome, but actually it's not necessarily getting at what is truly causing the symptoms. So what do we know about post-concussive type symptoms in non-concussed high school athletes? Here's more of that stuff about where those symptoms are not specific. So how many high school athletes, this is actually a huge study that I think Iverson was involved in again, but this is a big study of high school athletes that was back east, I think in like the Maine area or something. Anyway, they're reporting symptoms on a questionnaire. And based on those symptoms, would they be diagnosed as having post-concussion syndrome at mild or greater? But they've had no recent concussion. So maybe they had a concussion a long time ago, but nothing recent that would probably cause those symptoms. And it turns out 33% of boys with learning disability look like they have post-concussive syndrome. 50% of girls. If they have ADHD, that's a huge confound to what's actually causing these symptoms. There's the percentages, 31% boys, 52% girls. If they have both learning disabilities and ADHD before any kind of concussion, or in this case without a concussion, they look like they have post-concussive syndrome. 40% of boys, 59% of girls. Mental health treatment history, a lot of those symptoms are going to be reported even without a concussion. Substance abuse treatment. And then in the total sample, basically rounding, right? About 20% of boys and about 30% of girls with no concussion report post-concussive syndrome type symptoms. Think about these, they're athletes, right? If that's their baseline with no concussion, when on earth are we going to put these kids back into play in sports? If they get back to their baseline, they still look like they're reporting a heck of a lot of symptoms from concussion, and you don't put kids back into sports when they are still symptomatic after a concussion. No one's really talking about sorting that out. That's a big deal. Turns out the risk of kids going back into sports from having had a concussion and then the risk of what will happen if you have another one shortly thereafter is not actually as much of a catastrophic risk as we hear about in the media, but we'll get to that in a sec. What are the risk factors for prolonged recovery from sports concussion? So the research, again, that's been done, this is Mike McRae's group, and so 2015, what they found is that sports concussion patients with recovery time greater than 3 months, they were more likely than controls to have a concussion history, mood disorders before the injury, other psychiatric or mental health illness, significant life stressors, that kind of thing. Increased likelihood of post-concussive syndrome, family history of mood disorders, migraine. Now, some of this might be people with the very small group of people who actually are having ongoing concussion brain dysfunction. But most of these post-concussive syndrome folks are experiencing something else that was existing before they had a concussion and is now looking like a post-concussive syndrome. How about non-athletes? We used to think it was about 15 to 20%. I get asked by attorneys with some frequency in cases that I have to do depositions and provide my opinion about concussions and mild traumatic brain injury about this number because it sounds like a big number. Of all the people who, mild traumatic brain injury is about 80% of all TBI. The other 20 is moderate to severe. And so of all that big number, if 15 to 20% of people are actually ending up with a post-concussive syndrome, that they're just not getting better and shaking the effects of the concussion, that's a big number. Turns out that research was really, really flawed. It was done out of some studies in England. It was like one symptom ended up putting in this category. They didn't actually factor out litigation. Just as a reference, it's not on one of my slides, but some Scandinavian countries, I think maybe like Norway or something, doesn't have a litigation personal injury tort system where you get to say, I'm having a concussion that's a post-concussive syndrome, you injured my brain, and therefore I'm going to sue you, which is someone's right. But they don't have that system. We do. Post-concussive syndrome has a huge prevalence here versus next to no prevalence in that country that doesn't have litigation. And in that study that I mentioned that aggregated all the outcomes of mild traumatic brain injury, it was done in 2004 by the World Health Organization. The only thing that predicted someone having persistent post-concussive type symptoms after 3 months or longer, the only thing was litigation. It was whether you were potentially going to sue someone about your symptoms. I'm not saying that explains everything about post-concussive syndrome, but you can see where the sociology of the whole thing starts to tell you some things. So there was really flawed research coming out of England that got cited and inflated into that 15 to 20% number, but it turns out that the best prevalence actually estimate of how many people end up with a persistent post-concussive syndrome is about 1 to 5%. We shouldn't be treating people in the other 95 to 99%, and probably they shouldn't be showing up for treatment. It's that 1 to 5% that we're looking at that, geez, these people aren't getting better. But that's a small number. Here is the complexity of how mild traumatic brain injury recovers and things influencing it. I won't go through all of this kind of stuff, but some of it's psychological. There's social factors, there's motivational factors, there's injury-related factors. And so a lot of things go into that center thing of traumatic brain injury, symptom recovery, and functional outcome. And this complexity is usually not accounted for when people are being evaluated and treated for mild traumatic brain injury or concussion or post-concussion syndrome. So to the point of the talk, though, why all the concern about concussions? Second impact syndrome, you will see, is not necessarily a figment of imagination, but it's not a risk we need to worry about. And chronic traumatic encephalopathy has such flawed research that this will end up being sort of a smackdown of that to some extent. But a balanced smackdown because there's lots of reasons that it's poor research. So we worry about putting an athlete back into the game when they're concussed and before they've recovered because they could die. Their brain swells, herniates. Montana has a law, as do other states, and ours is called the Dillon-Steegers law. Dillon-Steegers was a football player who, what was it, like 6 or 7 or 8 years ago, died after playing football. I don't know all the details about that case, but presumably it was either the concussion was not managed well or he shouldn't have been put back in. I don't know if it was litigated, but basically the idea was this football player died, and maybe it was because he got his head hit twice to get concussions in rapid succession. This is not Dillon-Steegers. This is just something I found on the internet that suggests, a case of second impact syndrome. When I look at it, actually, it turns out he didn't actually die. But I guess the idea was that he had persistent disability after 2 shortly spaced concussions in sports. And here's what we know. So second impact syndrome is this is from Chris Randolph and Mike Kirkwood, who are neuropsychologists. This is the syndrome that is often cited by distributors of computerized cognitive testing. And you guys know our athletes now take what's known as impact testing in most districts, including here in Bozeman, before their season to establish a baseline of their thinking abilities on this computerized test. And then they take that test afterwards. Part of that issue there is that we wouldn't know if they were entirely recovered from their concussion if you have an athlete who's really motivated to get back in and therefore minimizes their symptoms, denies what's really going on because they just want to play. Although what we do initially is we say, how do you feel? Do you still have symptoms? If they say they do, they don't get to go back in. If they say they don't, then they would. Except the next thing they're going to have to do is to take the cognitive testing and see if you're better or if you're still impaired, how are you compared to your baseline of thinking abilities before you had that concussion? So the folks that created Impact Test, who are neuropsychologists like me, their contention and the marketing for the product in a large part is we can help you avoid kids dying from getting put back in too early and then having a second head injury when they're not recovered from the first by helping you to know when they're recovered from the first concussion, and therefore supposedly at lower risk to maybe no risk for that catastrophic outcome of dying from the second injury. So their contention is by ensuring that players have completely recovered from the effects of the initial concussion, the catastrophic outcome can be prevented. Obviously, we don't want kids dying on the football field, but we certainly don't want them dying from a second hit when we should have kept them out after the first one and not had that second hit happen too soon. But in fact, the majority of the cases of anything that would be called second impact syndrome in the literature actually doesn't seem to have involved a second hit at all. I'll tell you why in a minute. So the risk of permanent disability or death as a result of playing football in America and getting a brain injury, so a concussion, is actually, and they did the epidemiology here, these two, 1 for every 20,000 player seasons. So if there's one season in American football, therefore player seasons is kind of an annual risk per athlete. The red is more important, though, to think about. For a squad size of 100 players, this would be one such injury of permanent disability or death resulting from football head injury, one such injury on average every 205 seasons. That's not very common. The independent risk of this outcome is therefore approximately 1 in 1.8 million player seasons, or once in every 18,000 seasons for an American football squad size of 100. In a minute, you'll see just actually how rare this outcome might be. So Kirkwood, in a different article, said, in the sports setting, brain swelling of any kind is exceptionally rare. Catastrophic outcomes like death or permanent disability, more likely to result from subdural bleeding. So it's not the brain swelling, it's actually that someone had a brain bleed inside their skull associated with their head injury. That's actually not that uncommon. It's very uncommon someone would die from it, but it does happen. But that's different than the idea behind second impact syndrome. So it's probably bleeding inside the brain when it does happen. And the risk of a catastrophic outcome actually after sports-related concussion is very low. I can't emphasize how important that is because that is not what you hear in the media, and that is not the message. I mean, I was at the school board meeting when we were talking about instituting the impact testing, the cognitive testing, and the protocols for concussion for our athletes. And it was a good meeting, but no one was really talking about how low the risk is really of kids dying on the field. Here's the crazy one, though. If you're playing outdoors, all the kids who play outdoors sports, their risk, the whole entire population of outdoor sports kids, their risk of lightning strike death by playing outdoors under potential thunderstorms is actually higher than the risk of this catastrophic second impact syndrome death on the football field thing. Even people who have like heart attacks, you do hear about kids, right, who played basketball, and you think about Loyola Marymount, Hank Gathers back in the 90s or whatever. People die from heart attacks that just drop dead on the sports field or the court, and those plus lightning strikes are more likely to happen than this second impact syndrome. So what some other people have said about this is the scientific evidence, this is really strident language from scientists, the scientific evidence to support this concept is non-existent. They're anecdotal cases rather than good science, essentially, that's driving the idea of this. The fear of this condition has driven many of the current return-to-play guidelines following concussion. Again, why do we keep the kids out before we return them? I actually have a different take on this a little bit because I think that kids are students as well as athletes. But from the standpoint of them being athletes, why do we keep them out from play until they seem like they're recovered from the first concussion? A lot of the time, it's because we're worried about them having catastrophic outcome like permanent disability or dying. If second impact syndrome exists, then its occurrence is really, really rare. And arbitrary exclusion periods from sports, sitting them out, based on a fear of a non-existent entity is not the answer when we actually need to look at the data in medicine. Just something that's not in a slide here that at least needs to be said is there are some people, our kids, athletes, some people who are genetically probably vulnerable. And that's a hypothesis. That's not, we know what genetic syndrome or variant they have or something and can identify those kids by genetic analysis. But there's probably something genetic that predisposes kids who play sports, not kids who play sports, kids, and therefore the ones who play sports, to having bleeding inside the skull and dying from that bleed just because they play and they got a head injury. But it's not the second impact, it's the first impact. So holding them out isn't really about the second impact syndrome. So what about chronic traumatic encephalopathy? These are some folks who have been purported to have died, most by suicide, as you probably know, and their brains were sliced up and they said, yep, here it is, there's the brain disease. So again, 87 out of 91 former NFL players that have been studied in Boston seem to have it. So supposedly, what is it? This is Iverson again. It's a review of chronic traumatic encephalopathy in terms of all the science, and it's a really good article to read. In the papers presenting the cases by autopsy, so you can't diagnose chronic traumatic encephalopathy in someone's life. You can only do that by slicing their brain after death and seeing if it's in there, whatever that it is. So autopsy cases saying, yep, we found CTE, and all the subsequent review papers. The authors have said this is what it is. It's a unique brain pathology associated with this chronic traumatic encephalopathy. It's caused by brain trauma. The Boston people say repetitive brain trauma. Bennett Omalu now says it's only one single concussion in your whole lifetime, and that can cause this disease later. And that even in small amounts, like if we slice the brain and just see a tiny little bit of these supposed abnormalities, that even in that small amount in the brain overall, that still could cause really complex changes in someone's behavior and their thinking, make them look like they have a dementia, essentially. So you can have depression, you can have anger, you can have can't control yourself, you can have suicidal thoughts, commit suicide, cognitive impairment, all these things based on a little bit of brain pathology that they say would cause that. So what's wrong with CTE research? A lot. The media doesn't think about this all that much. And there's been a lot, right? I mean, you had Frontline as, the PBS, public broadcasting, they kind of did their investigative stuff. And you have Sports Illustrated and, sort of respected media channels to some extent that I would say have actually taken the poison Kool-Aid and just drunk it wholesale. Samples of convenience. Who actually gives their brains to be studied? Is that all NFL players who were retired? Heck no. It's only a subsample of people. So there's some bias in who gives their brains. You guys know one of the NFL players actually committed suicide by shooting himself in the chest with a note saying, "Give my brain to Boston," so that he didn't shoot himself in the head. Inconsistent neuropathological findings. So all these brains have CTE. Really? Because actually there's a whole bunch of different brain tangles and problems and brain cell abnormalities and so forth in the brains that you guys actually said have CTE. So there's not really this unique singular thing. And until 2015, there was no consensus of people saying we think this is usually what we would find. That exists now, and that's an advancement in the science because now you can actually have some standardization to who you're studying and how. Whereas before, there was one of the studies, I didn't have a slide about this, but Chris Randolph, who the neuropsychologist who talks about this with some frequency, he actually makes the point that one of their so-called cases of chronic traumatic encephalopathy was an alcoholic dwarf man who was shot out of cannons in circuses for years and years and years. Not that that person couldn't have the supposed chronic traumatic encephalopathy, but maybe alcoholism had a little bit to do with it. So turns out that the neuropathology, what they say is the actual brain abnormality, is called tau. And tau is a protein in the brain, and when it gets what's called hyperphosphorylated, it ends up decomposing, breaking down, and its structure is yucky, and so the plaques and tangles you see in Alzheimer's disease are because that protein structure of tau has just gone, to pot. And so that tau damage is what they say is core to chronic traumatic encephalopathy. However, it's actually common in normal aging. You'll see just how much. Well, they've got a whole bunch of different symptoms. All sorts of things. If it's in the psychiatric diagnostic manual, chances are that it's been attributed to CTE. If it's a type of dementia that is in one part of the brain but not another, chances are those symptoms might fit the criteria. Another type of dementia that's in a different part of the brain might fit the criteria. It's just really, really diverse. And so it's not really actually a unique clinical syndrome. It's just sort of like a whole bunch of symptoms that a lot of people could have. Pathologically and clinically, there's substantial overlap with other conditions. So I mentioned that different dementias like Alzheimer's, frontotemporal dementia, different real brain diseases that have been uniquely identified. There's a heck of a lot of overlap. Literally, they will find those abnormalities in the brain cells in some areas of the brains of the people who have been said upon autopsy to have CTE. And then suicide. So suicide in particular, depression to some extent, but suicide has actually been kind of this, wow. If you have an NFL player who's retired who commits suicide, boy, get their brain because they might have CTE, and they oftentimes say, yeah, we think we found this in that brain when the family donates the brain. Turns out actually that retired NFL players are actually at lower risk of suicide than non-NFL retirees. If you played football, whether it's, the money, and sometimes they certainly blow through that, but there's something that looks like it's actually protective against being suicidal in retirement when you played NFL, not the other way around. So I'll go through these pretty quickly because I mentioned some of them before, but some of the quotes are interesting. So ascertainment bias. Who sends their brain in to get studied? It's not the whole population of people who ever played football or contact sports who might have CTE. It's somebody who committed suicide. It's somebody who died early. It's someone who had problems during their life. And then that's just attributed to this dementia attributed to repeated concussions. So it's not a random sample. It's just the ones that were volunteered to go to the brain folks in Boston, or now Bennet Omalu is doing a lot of this research, but with deceased military folks. Doesn't represent the overall population of people who might have CTE from repeated concussions, say in sports. And it actually is an overestimate of how common this is, what the rate is of CTE in athletes. And maybe there's just other factors that are unrelated to this supposed brain disease that lead to symptoms in life, but again, unrelated to that, that are why people donate their brains or why they killed themselves or whatever, that just aren't this actual brain disease. Because it's a non-random sample, you don't really know. You just know that these are the brains that got chosen to come to us. So research to date has examined convenience samples of athletes who did donate their brains and that were actually experiencing clinical symptoms prior to their death. This has unfortunately led to misleading headlines about the risk of developing this supposed pathology and estimates of its prevalence being inflated. I should mention this study from Askin doesn't actually say this is not a thing. It just says, man, we're oversimplifying this. So, inconsistent pathology, lots of different damage to brain cells, including things that overlap with Alzheimer's and different types of dementias that aren't necessarily a unique dementia called CTE. And actually, not all individuals, you'll see a slide about this in a sec, but not all those people who are identified as having that pathology when they sliced their brains actually showed a dementia or problem when they were living. They might have actually been normal. Maybe the person died of a heart attack or something and had their brain studied and didn't necessarily have any problems. And then they go, aha, here we found it. But it didn't really cause any problems if it could have. And then not all those showing CTE dementia in life actually show an abnormality in their brain. So there's not really a good correlation there between those two things. I mentioned that abnormal tau, this protein with the brain cells, is common in normal aging. Here's just how common. The best staging of Alzheimer's, like the more Alzheimer's pathology you have in your brain, the more severe your Alzheimer's dementia is, like from mild to moderate to severe. They've actually sliced brains at different stages of Alzheimer's, and they find increasing, as you would expect, increasing amounts of that brain pathology in the brains. And then Brack and his wife and some other colleagues, they are the ones who have sort of staged this. They'll say, this is stage 4 or whatever, and that probably correlates with just how severe the dementia was because they're finding more of that problem in the brain. Well, they've actually taken a look at how common this is in healthy folks. So 100% of people over 30 years of age who have been autopsied in their studies, 100% over 30 showed some of that pathology there. Do they have CTE? Not really. And then 90% of those over 10. It's pretty crazy. In the Honolulu Asian aging study, at autopsy, men who were cognitively normal at their last exam during the study, 54% demonstrated various brain damage pathology, including these tau abnormalities. But they were, again, not experiencing any cognitive problems when they were examined before death. Too diverse to represent a unique clinical syndrome. I love this quote because it just encapsulates the whole thing. The features of CTE in the literature, they're so broad and nonspecific that a former athlete, a veteran, or a civilian with depression, substance abuse, and anxiety, anger control problems, and traumatic stress, cognitive impairment, frontotemporal dementia, or, and that's or, not and, or Alzheimer's disease, singly or in combination, could be conceptualized as having CTE. They haven't done a very good job in saying these are the features of CTE, but not of other things. A lot of overlap with other dementias. I mentioned that before. Many of the cases that they said there's CTE here, they went, oh, and there's also these other brain pathologies that are associated with Alzheimer's and associated with frontotemporal dementia and so forth. In fact, enough to even meet criteria for a pathologist to look at the brain and say, yes, this person had Alzheimer's. And they go, no, they had CTE. And then someone says, well, maybe they had both. Here's a crazy one. 1 in 4 people identified as having the neuropathology of CTE didn't have any clinical symptoms, but 1 in 4 people with clinical symptoms had no demonstrable CTE pathology. And suicide is not a specific criteria for diagnosis of CTE. It's been considered a common clinical feature. It's in the media a ton. But there's no published actual studies showing a relation between contact sports, chronic traumatic encephalopathy, and risk of suicide. And as I mentioned, NFL players are at lower risk after retirement than non-NFL retirees for committing suicide. Not higher risk. So that really can't quite work. And the complexity of causes, this is from the Askin study that I mentioned earlier in 2016. So it's likely that there's a bunch of factors that actually are kind of mucking up the works. They're moderators, they're mediators, they're kind of associated with. These guys didn't say CTE doesn't exist, but they said if it is there, you got to account for all these other things that might be causing the symptoms, moderating the symptoms, leading to the expression of this supposed brain disease. By the way, punch drunk syndrome, boxer's dementia, even Muhammad Ali, he probably would have gotten Parkinson's anyway, but he got it worse and got it, sort of earlier and so forth because he was a boxer and had his head hit a bunch of times, probably. No one has the market cornered on that, but it probably worsened things or brought it on earlier. And in fact, that's one thing that we think is that if you hit your head a bunch of times and have a lot of concussions, it's not a good thing with regard to the health of your brain that could otherwise withstand a dementia that you might otherwise get anyway. So CTE may sort of be a thing, but again, there's a lot of problems with the research. And so look at this. I mean, someone's SES status when they're growing up, economic status. A lot of NFL players, don't grow up necessarily with the best resources and family money and so forth. Maybe that has something to do with the health of your brain later in life. If they have ADHD or learning disabilities, if they are adjusting to retirement. This article spends a lot of time talking about, people can look like they have this dementia syndrome in life, maybe because they're adjusting to retirement in a way that's not so easy. Drug and alcohol abuse. Obviously, you have athletes doing steroids and opioids for pain and stuff like that, alcohol, drugs. They've had surgeries, they've had anesthesia, they have sleep problems. A lot of these things could be leading to the symptoms that they say are this particular, specifically caused by this brain disease. So is it even real? Chris Randolph has a lot of things to say about it. He's a little bit of a lone wolf in that way, but I actually like a lot of what he says. So these folks from Boston published in 2012 an article that kind of said this is what CTE is, 5 proposed stages. He said there's 2 problems with the hypothesis, which I've kind of mentioned before. The first is that just because you have this particular pathology in the brain, abnormal tau, that's not specific to this condition, and it occurs in a lot of other ones, including normal aging. So that's kind of problematic. And then the second is that just because you have that doesn't actually mean that you have a brain disease that's getting worse and worse. It doesn't even guarantee that you have any associated problems with your thinking or your behavior. I'll go through this one without talking about it too much. So what's wrong with athletes thinking that they might or have or might get CTE? They don't know, right? It can't be diagnosed during your life. It's impossible. Maybe at some point we'll have something that kind of gets us closer, but right now you can't. It's just on autopsy. But they think they might get it. And in fact, a lot of NFL retirees are watching the media. They're seeing all these reports. They know some buddies who are saying, man, I can't think quite well, and I'm feeling irritable, and I'm having all these symptoms that could come up for a lot of different reasons. What's wrong with that? So Randolph said, look, it's not only premature to suggest that people who are retired from contact sports are at risk for CTE, period. He said it's actually dangerous, potentially, because that might actually make people think that even just depression, which is said to be a core feature of CTE, they might have depression and they misinterpret their symptoms as indicative of the first stages of a fatal neurodegenerative disease. So here's the joking version of why that's bad. The Onion published this back a few years ago. So neurologists say, please, wait until you're actually not alive anymore, until you send us your brains. Don't jump the gun. But the tragedy one is this. So Todd McEwen, this may have happened in other folks, but Todd McEwen was an NHL enforcer, had concussions during his sporting career. He was convinced, according to his wife, that he had CTE. He thought he was going to go downhill. He thought it was incurable. He hadn't been diagnosed. He hadn't been evaluated. He was depressed. He committed suicide, so he's gone. Turned out his wife said, please study this brain, and they found nothing. He didn't have anything. So Bill Barr, who's yet another neuropsychologist, he says, what this slide basically says is most athletes fully recover in 1 to 2 weeks, but the media pays a lot of attention to the stories of athletes seeming to not do that. High-profile professional athletes, longer periods of time to recover. You guys know that Sidney Crosby is the poster boy of that from the Pittsburgh Penguins. It's not to say he hasn't had concussions, but he's the poster boy for prolonged recovery from that. Highly publicized accounts of high-profile cases can give the public kind of a biased perception of how much, what are the rates of recovery. Again, 10% of athletes, 1 to 5% of overall concussions have any persistence of symptoms beyond a spontaneous, fairly rapid recovery, and the public thinks it's much more. I would actually argue that clinicians think it's much more than that too. Such a bias can result in what social scientists have termed the availability cascade. So essentially, we ignore the overall data because we have these really, really sort of hysteria-hyped examples of what we think happens, really dramatic individual cases, but we don't necessarily pay attention to the science. And one of the things that Chris Randolph has said about Cte Research is we don't have the epidemiology. We do not have the overall studies of good studies of how prevalent this is in overall athletes. We just have a bunch of people who selected in some biased way to send their brains to the brain bank, or their families did. These folks talked about something that Iverson had said. So ongoing publicity about brain damage in the media after sports concussion actually might worsen recovery, because recovery is in the eye of the beholder to some extent. And if people think they're not going to recover, then that tends to bias their perceptions of their symptoms and their recovery. So Iverson and his colleague said that it's important to avoid over-pathologizing the test scores that we have from cognitive tests and the post-concussion symptoms. Over-pathologizing, right, meaning, wow, this is evidence of brain damage. You have a damaged brain. You're not recovered from brain injury yet. Because this can inadvertently cause athletes to feel undue stress, anxiety, and depression. And in fact, athletes who worry and focus on their symptoms are at greater risk for reporting that their symptoms don't seem to be resolving in a typical, spontaneous, reasonably rapid way. So one of the things that I see in my work as a neuropsychologist is that sometimes treating concussions makes it worse rather than better. Here's some statements by, again, Iverson. He's said a lot about this, so he's a good resource for these quotes. We have seen psychological harm resulting from people being told that they have brain damage, And they'll need to cope and compensate for that damage when in fact the probability of permanent brain damage from a concussion was very low. And the probability of actually a treatable condition, depression, anxiety, sleep disturbance, those are not permanent brain injury or getting worse. Those are things that you can treat. Cumulative life stress, that was actually high probability of the cause of those symptoms they're reporting. When a person is misdiagnosed as having presumed permanent brain damage, it sends a strong negative prognostic message. In fact, the diagnosis can be countertherapeutic, reinforcing that misattribution of all symptoms to brain damage from a concussion, and then leading to a sense of hopelessness regarding future improvement. This is what's called the nocebo effect, in essence. The expectation of illness and illness symptoms and getting worse and not getting better makes you have symptoms and makes you feel worse and not really seem like you're getting better. So, again, Randolph says, look, as it comes to CTE, it's not just premature to suggest that sports retirees are at risk for this, but it's actually potentially dangerous. And I would say that I think right now what's happening in almost every single clinic that someone could go to and say, I'm a retired athlete, or I've played sports and had multiple concussions, or I've had multiple concussions because of a car accident multiple times or whatever, and I'm worried about what I hear in the media about people getting dementia and having permanent disability from multiple concussions. I think what's happening in those clinics most of the time is that people are actually not being told the right thing, and I think they're being made worse by people saying, yep, that could be, or maybe it is. So having said all of that and sort of, criticizing the research and so forth, but actually mainly talking about there's a really good prognosis and outcome from concussions in general, even repeat concussions, assuming someone gets better and, isn't still having cognitive dysfunction and so forth on the testing. Where I would say those are sort of relatively reasonable to low risks of, anything really bad from getting concussions in sports. How's that stack up against the benefits of actually playing sports? And so none of these are going to be, weird to anybody here. The benefits to playing sports: gain fitness and health, learn teamwork and perseverance, develop foundation for lifelong fitness, make friendships, happy self-esteem. I'll talk about the academic piece in just a sec, but I want to say with regard to the benefits and the risks that I just saw someone in clinic who is a teenager who was told by a sports medicine physician at a regular old sports medicine physical for sports, you've had 2 concussions. History actually was probably one of them wasn't, and one of them definitely was. But it was a while, it was like 3 years before this physical happened. And the doc said, I will clear you, but if you have another concussion, this could be catastrophic. And you're done with sports, but this could be really bad. You could be dysfunctional for a long time. You could potentially die. I don't know if all this was said, but definitely this could be bad and you're done if you have another concussion. I would say that was the wrong message to say to this kid. There is no magic 3 and you're done. In fact, you guys know Mickey from the impact research and the UPMC stuff. And in a training that I did with Mickey Collins is the one who developed the computerized cognitive testing for sports concussion work. He said, I don't have a magic number. The issue, I've put people back into play in sports when they've had 7 concussions. But the thing is, after the 6th, they got better. And after the 7th, they got better. If they have an 8th, and then they're not recovering, and they're really still symptomatic and pretty dysfunctional, then that's not good, but it doesn't mean I couldn't have put them back in on the 7th one. So 3 is not a magic number, and my patient that was told, if you have another one, this could be bad, I honestly think had a typical recovery from having had another concussion, which did happen subsequent to that, but that's sure not what happened emotionally. This poor kiddo is almost a boy in a bubble with regard to what parents are allowing the child to do in terms of sports and so forth. And here's an interesting one. I didn't mention brain rest in here, but I had some slides about it. And what I'll mention is what you're told a lot of the time these days in managing concussion is something to the effect of, on the extreme, like go to your basement and have dark and don't have any light and don't look at screens and don't think and just, like be almost like you're comatose, and then you'll recover better from the concussion, which is ridiculous. But a lot of what's being told is brain rest, like don't think and really go back to school and think about stuff, don't really do a lot of cognitively demanding stuff, and rest a whole lot, but mainly brain rest. Well, it turns out that they actually did a study where they randomized kids who had gone to the ER for sports-related concussion. They randomized these kids to either get the typical ER doc, what they say, which was, things like wake them up every so often and come back in if you deteriorate, but otherwise, don't do much and get better. And then they took the other group, which is the treatment group, and they did what is becoming more common now, which is they said, you can't see your friends, you can't go to school, you can't do any screens, no social media, no nothing, brain rest. And they made them do it for, I think, like a week, which isn't necessarily that long. Which group actually had more post-concussive symptoms after that week? The ones who had been told to rest. And the hypothesis is you basically just took a bunch of teenagers who want to be with their friends, want to be on social media, don't want to be held out of school, don't want to be held out of their activities, and you made them do that. For what? So their brain would recover better? We don't have any evidence that brains recover better when you don't think, when you don't do anything. So now you've actually got the person being worse by what you thought was potentially going to make them better. So that's what I got in terms of slides. Time for discussion.
Yeah, a couple questions. Regarding the metabolic changes, is that the same with young kids, like
as
10,
far as I know,
5, 6, so all ages? That's
as far as I know. I mean, you're going to have something different potentially with the way that the body works at different ages and how developed certain systems are. But to my knowledge, the disruption and the chemical disruption and that kind of graph, looks pretty much just the same for young ones.
And when would you typically test somebody for neuropsych testing post-concussive? Would that be post 3 months, or when do you?
It depends on what the decision is. So if the decision is to get them back into play, then we want to be able to test them as soon as they're reporting that their symptoms seem to have resolved, and then they go through the graduated protocol, right, of sort of increasing exertion, and if they remain asymptomatic, then you can cognitively test them. Of course, there's the impact testing that might just happen anyway, and they wouldn't get referred to me. But I don't know how much you guys know about just how poorly performing impact testing actually is. You expect it to be reliable, because if you test a kid at baseline and then they have no concussion and you test them again a second time, they should score about the same, right? So it should be reliable. It shouldn't be significantly higher scores or significantly lower scores. It turns out that with the impact, the actual data shows that when you take, with that test, it's a little bit better if you look at multiple indices of their performance. But basically, if you looked at one of the areas of their thinking that test tests, say concentration or memory or whatever, that if you take kids who have been tested serially but no concussion in between, and you expect the second scores to be similar, it turns out that about 35 to 40% of the time, the scores are significantly lower than they were before, and sometimes significantly higher. And so that's a false positive, right? The kid didn't have a concussion, they don't have any brain dysfunction, but their scores went down, and that's actually, it turns out, because there's poor reliability of the measure. So what that means actually is that if it's really that bad and you're using it to determine return to play, so asymptomatic at rest, asymptomatic with exertion, and now we're going to do cognitive testing, I don't know about anybody else, but I don't want something that is wrong 40% of the time. And it turns out it's not just wrong in a false positive way of saying, yep, you're impaired when you're really not. The flip actually would be true. it actually would have a false negative. So it's missing impairment that's actually there about 40% of the time because it's not a reliable measure. And so the trick is with return to play, I'm just using that as an example, and that's not where I'm going to go as sort of a second part of my answer to the question. But with return to play, the goofy part is that by the time that they're asymptomatic with rest and then with exertion, they shouldn't really be showing any cognitive impairment on the testing anyway, but then you're going to potentially use a measure that gets it wrong a lot of the time. And our orthopedists, bless their hearts for doing all the sideline stuff, right? And sports medicine for the teams, but they're just looking for scores that are in bold on the printout, and they don't know how to interpret it other than that. So they don't know if it's going to be bold 40% of the time wrong, and it's just not a good measure to use. The problem is if they're going to get in with me, not only should they be normal in their cognitive testing anyway by the time they're reporting no symptoms, but then it's going to be hard and laborious to get them in. Now, someone might say, well, you don't have baseline testing from them. It turns out it doesn't really matter, and there's been some research that shows that you can do just as well by just saying, how do you compare to kids your age? And someone like me is in a better position of actually, looking at whether there's premorbid ADHD or learning disabilities or what should their scores have probably been before, rather than just interpreting low scores as impairments that would be concussion-related, therefore you're not recovered. So it turns out that the signal versus noise, the signal ratio that you're going to get from cognitive test scores in concussion and return to play, there's an overlap where you're going to get abnormal test scores on cognitive testing, say we did it in my office, during the time when they're symptomatic, but you shouldn't actually get that by the time that they're asymptomatic and could be return to play. And so the only time you'd really want to do a return to play true cognitive testing, let's see if that really matters, if that tells us they could return to play because their brain looks recovered, is actually during the time that they're symptomatic, which you wouldn't return them anyway. And so cognitive testing is, I think it's actually going to be shown, and this is odd from a neuropsychologist standpoint, right? But I think cognitive testing, which is my bread and butter, is going to be shown to be nearly useless for return to play decisions. And then you think about return to play, but what's the risk? My issue is that they're athletes and they're students. And so I actually care a heck of a lot less about whether they're put into the game and return to play. I'm fairly liberal with that. I care about whether they're cognitively dysfunctional and they're students and need accommodations, because they're going to continue to try and get good grades, which is more important than their athlete stuff anyway, in the weeks after they have a concussion, but we don't necessarily focus on that quite as much. So I think a cognitive, to kind of blend the answer to your question, I think a cognitive evaluation can be useful to help with that aspect much more so than a return to play aspect. In everyday concussion and a year later, 9 months later, 2 years later, post-concussive type syndrome folks like we all treat, I think that neuropsych evaluation with cognitive testing is super important. For example, we would be able to tell if someone actually had no cognitive impairments, even though they're reporting subjectively that they feel like they are, and then we can be really reassuring. It may be odd to them, and they're like, well, wait a minute, how come your tests didn't pick up on what I know is happening? But our tests are objective, and they're actually, frankly, better than someone's subjective perceptions of that. Perceptions can be pretty colored by a lot of things. And so if we do cognitive testing and we say this is actually normal and no cognitive impairments, that's hopefully reassuring, and it certainly is objective evidence that the brain looks okay. What else is going on here? And that's when we can bring in the differential diagnosis of what's going on psychologically as well. And a lot of the time we see results that look like depression or somatization, right? The tendency to develop and exacerbate physical symptoms in response to depression or what's going on psychologically stressful inside somebody. So that's what needs to be then treated. And that statement by Iverson and his colleagues, we need to actually identify the pain, depression, sleep disturbance, and things that are causing post-concussive syndrome. Overwhelmingly, most commonly, that is the case the longer you get from a concussion. And I would say, in your guys' practice, if you see folks who are coming to you and they're reporting that the presumptive injury causing the post-concussive syndrome is, 3, 4, 5 months or longer afterwards, there's an overwhelming likelihood that it's not brain trauma anymore. And I know that may seem like heresy in a way compared to what we hear or even what the therapy world talks about in treating brain injuries, but it makes people worse when we say you are now compensating for, and I know you guys have a very, your model is very focused on optimism and getting people better and so forth, but when you get them when they're a long time after, you're not treating, whatever the nystagmogram and anything else says, you're not treating brain injury anymore in almost any case. Now, I do see people sometimes, it's a very, very, very minority of the time, but I do see when we do the cognitive testing that they have some abnormalities, and maybe there's nothing else to attribute it to other than, darn it, your number came up and you're one of these very, 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 very few who had a concussion, and it's something of a permanent mild TBI. But that's super, super rare. And so I think that when to do the cognitive testing, you can do a neuropsych eval at any point when someone seems to be in a persistent post-concussive type of syndrome. The ER does send me people who have been seen at the ER with concussions and they're only maybe a week or two out of the injury. What we end up doing there is we say, we expect to see some cognitive dysfunction, and we probably do. And then we can tell people what they are and make them feel like they're not going crazy and really identify where those cognitive deficits are. And then we can actually get them into more of the active rehabilitation, and they might see you guys for anything that's vestibular or physical. They might see, speech therapy here at the hospital for their cognitive dysfunction to compensate for that in the short term. But even our speech therapists are going to kind of say, this is just, short term, we'll help you out while you're still symptomatic. But our cognitive testing might have provided a roadmap to focus on the things that need to be focused on in terms of compensating. That's the longest winded answer you've ever gotten, probably.
That was good.
You had questions, I think?
You answered
with my long-winded answer? With my long-winded answer?
Let's just do the presentation.
I might just throw a couple things out real quick.
Sure.
Because I'm 70, so I'm old, okay? But so you start guessing, what's happening because you're getting old. What's Alzheimer's versus could have been by concussion, and I guess it doesn't really matter when it all comes down to it. But is Alzheimer's or short-term memory loss associated with concussions long-term like that? Can it, where you had I had 3 knockout concussions when I was young, but would that even be affecting me now? Or would the fact that I lost my wife 3 years ago and my memory went away for a year or two, I feel like I'm getting better. You probably shouldn't worry about what's causing it. But it's the concussions, I can't really pin down what's happening in my mind or whatever to being from concussions necessarily.
Well, the first question is whether someone's thinking and memory is abnormal for their age, regardless of the cause. And so cognitive testing that has normative data for what's typical and normal for someone's memory and concentration at a given age, which all of ours does in neuropsychology, and when we do cognitive testing, that'll tell someone whether there's even something to worry about or whether it's just normal for age. If it's not normal for age, it can't be Alzheimer's, because Alzheimer's is a pathology that is way worse memory functioning than what would be expected for age. Initially, it's a little bit worse and eventually gets a lot worse. But you'd need some, objective evidence as to whether it's sort of, age-related difficulties that's normal for age versus something that's actually more of a abnormal disorder. Then you can get into what could be the cause of that potentially. I just did an evaluation with someone and gave feedback recently to that person where I said, not only are your cognitive test scores normal for your age, and I get that you're feeling like your memory's not very good, that's why you came to me, but your cognitive test scores are actually normal for your age. There's no disorder here. But you're pretty darn depressed, and depression causes difficulties with, concentration and memory. So in that person's case, I say, well, the good news is this is treatable. This is called a pseudo dementia of depression. We treat the depression and the person's thinking gets better. There were other factors there, but that's a heck of a lot better prognosis when we can tease that out than an incurable, untreatable, worsening brain disease. And I think it's the same actually with concussions and post-concussive syndrome, because it's a really, really bad prognostic message that sets someone up for expecting the worst in the future if they're told you may have to compensate for this forever and you may never get better, even if it's mild deficits. If that's not really what's going on, and based on what I presented, that's usually not really what's going on. And so identify the other causes, treat those things, and there's a heck of a lot better. Someone's going to get better by treating those things rather than have sort of what we consider like a brain injury identity of sorts and attributing their problems to that. A lot of hopelessness there.
Mm-hmm. Yeah, just normal. So if you do something like, I'll give you a real specific example. So about 3 months ago or whatever, I sold an old handgun. I was a security guard when I was going to college 50 years ago or 60, whatever. But anyway, so I went down to Schnee's about 2 weeks later and told the gentleman, I said, I've got a 38 special handgun I want to sell. And he says, you brought that in and we already sold it for you.
Right.
And that was like, whoa. That was something that was really kind of short term, a few weeks after it happened, that really hit me like, whoa, what's going on with this short-term memory deal?
Right. Well, you can always talk to your primary care doc and see if they would, think that you should get some formal cognitive testing, like at the Neuroscience Center, and then you can kind of see how things look, whether they're normal or abnormal. I would even say that that's concerning to a person who experiences it, but it may actually not be evidence of a dementia.
Yeah.
Even at the kind of earliest stages of that may actually be normal for age 2.